You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
Comparisons of national indexes are once revealing and misleading. The United States, for example, ranks high on national income, trailing only Switzerland, Norway, Luxembourg, Qatar, and Iceland. Yet white American households' incomes average $70,600. That of Hispanic American households is $51,400, and that of Black Americans, $41,361, or in percentage terms, 73 and 59% respectively of white households. Infant morbidity rates per thousand births vary dramatically, from Afghanistan's 110 to Somalia's 86, to the French rate of 3 and that of Cuba 4, and the American rate of almost 6 per 1,000 population. If, however, we compare maternal morbidity among racial ethnic groups within the United States, the results are stark. Black infants die at a rate twice that of Hispanic and white infants. Similar findings are revealed for maternal morbidity. The United States has the highest rate of all developed countries and is the only developed country with a rising rate of maternal morbidity. A large part of that rate are Black American women dying from childbirth at rates nearly 4 times higher than those of Hispanic and white women. Race and ethnicity are important factors in any effort to make sense of these numbers and the human tragedies they represent. But race and ethnicity are not the only factors. For some time, researchers have questioned whether and to what extent America's 400-year-old history of racial prejudice contributes to clear and persistent disparities among racial and ethnic groups of Americans. And even as members of some of the traditional professions, medicine and law, condemn prejudice and work to increase the numbers of racial and ethnic persons to join their professions, the results suggest that bias persists. And what of the people served by physicians and lawyers? Notwithstanding the disclaimers of prejudice, does bias impact how they receive services? We turn to someone especially well informed on this question. Cristina Gonzalez is professor in the Albert Einstein College of Medicine and attending physician in the Montefiore Medical Center in the Bronx, New York. And in turn, she was recognized by her colleagues in 2011 with presentation of the Unified Leadership Training Award for the Association of Chiefs and Leaders in General Internal Medicine. In 2016, Dr. Gonzalez was one of only 5 recipients selected as Macy Faculty Scholar and received a $100,000 grant from the Josiah Macy Jr. Foundation to enable her to continue her medical education research and curricular development. She is only the second education researcher to be selected as a Macy Scholar in its 30-year history. Dr. Gonzalez completed her undergraduate degree at Penn State. She completed her MD at Albert Einstein College of Medicine in both her residency and internship at the Presbyterian Hospital Weill Cornell Medical Center. Of particular note is her decision to earn a master's degree in education. More often these days, physicians earn graduate degrees in public health or Master of Science in Research Methods, or, as was the case 15 to 20 years ago, an MBA. But Dr. Gonzalez chose a master's in education, and I asked her in advance of today's interview why she chose a rather distinctive path of professional development. And her response was straightforward. My ultimate goal, she said, is to design interventions, and I suggest she is focusing on educational interventions that minimize individual clinician contributions to health disparities and thereby contribute to achieving health equity. Welcome to Innovators, Dr. Gonzalez.
Thank you.
Allow me to quote from a release from your alma mater employer, Albert Einstein College of Medicine. Can asking uncomfortable questions reduce health disparities? Recent studies found that racial and ethnic minority groups are particularly affected by persistent disparities in healthcare access and quality. But physicians who are willing to take an extra moment to question their patients and themselves could provide better care and help narrow the healthcare gap. Surely the persons who undergo the education and training as scientists and physicians, surely they lose whatever vestiges of prejudice or bias they may have acquired in their life. If nothing else, it seems to me the Hippocratic oath each doctor takes implicitly bars a physician from acting in a way that somehow diminishes the care she or he provides a patient, regardless of race or ethnicity. And yet, your research and that of others suggests that implicit bias can be every bit as distorting as conscious racism or misogyny. So tell us, what is implicit bias and how does it find its way into the relationship between a doctor and a patient?
When you think about implicit bias, I like to explain it as the unconscious and unintentional mental associations that we make about different social groups. And more in the last several months, there's been attention in the national dialogue to systemic racism. Right? So there's many different types of bias, but if we want to focus on racial implicit bias, again, unconscious and unintentional, why do we make these mental associations? Right? Why do we have negative mental associations about some groups and positive mental associations in a blink of an eye about other groups, right? And so a lot of that stems from the way that we're socialized and the way that structures are in place and media, movies, etc., portrays different groups of people. And so we're socialized in this environment, and then when we're doing what's called type 1 thinking, very fast thinking, we rely on these unconscious mental associations, which is implicit bias. And everyone's implicit biases are unique to them based on your lived experience, based on how you've been socialized. And so that's what they are. So again, they're unconscious, unintentional. They are human nature. Human beings have them, but the good human beings have them. In other words, they don't imply that you're not a good person. I want to make it abundantly clear. And so when you think about how do they seep into the doctor-patient relationship, if I understood your question correctly, then you have two humans in a room, both with lived experience, both with socialization, and implicit bias is a cognitive shortcut. It's a mental leap you make. And so you've got it's more activated when you have time constraints, you're fatigued, there's some uncertainty, and there's ambiguity, also known as every day at work. So,
I was going to say that sounds like the world of just about everybody.
Exactly.
But especially physicians.
Because of the fast-paced nature of what we do. And so what we're hoping to have is have people have increased awareness and skill building, which we'll hopefully get into in a little bit, so that they can recognize when bias is impacting the clinical encounter and then mitigate its negative influence. But that's how it seeps in. We're socialized, it's mental associations, they're unconscious from good people, but even though it's not our fault that we have them, right, they do influence our behaviors, and because we have domain over our behaviors, that's where our responsibility lies.
Is it safe to say that it's a way of making sense of a situation that in the best of circumstances, a physician has limited information and is usually in a set of circumstances that require, to lack of a better phrase, a snap judgment in some cases? Does that enhance the power of implicit bias?
It enhances their activation, absolutely, and our reliance on them. We have all kinds of other cognitive biases, anchoring bias, recall bias, that we talk about all the time in medical decision making and diagnostic error, for example. But because implicit bias has this extra layer of a kind of an emotional charge, right? You can be like, oh, well, sure, I have anchoring bias, and you even don't want to have that where you just thought of a diagnosis and kind of closed off your mind too quickly.
And that's it.
But the racial bias or ethnic bias or gender, any construct makes you feel guilty. And when you feel guilty, you shut down and get defensive. And our work really works to capitalize on people's good intentions and engage people in a productive process and completely avoid blame.
But that's fascinating because you're suggesting that individuals who are aware of implicit bias, it may actually have an even more powerful effect because, as you say, they're somewhat ashamed of it. They are aware of it, and therefore they are ashamed of it. And that may actually cause them to avoid it to some extent because they're afraid that that bias will reveal them to be somehow less than humane. Am I right?
It's one of the best questions anyone's ever asked me. Absolutely. Exactly. So there's this assumption that awareness is enough. A one-time event, you're aware, congratulations, keep being a good person, and now you've got this problem solved. And what happens is exactly what you said. If there's no skill development, right? If there's no further engagement to actually get to skill development, then people are aware, and because people are good people and don't want to hurt others, there is literature supporting, research studies that have shown that there's avoidance then because of the groups you find out you're biased against because you don't want to hurt them, but you don't know what else to do. And so if avoidance doesn't help anyone. Go ahead.
So you can create awareness, you can enhance awareness, but in the absence of something that tells you what to do with that guilt, whatever, it really doesn't change very much, does it?
Correct.
Let's go to a question that I've thought about a little bit more. You've written, and I'm going to quote you here, which is always the worst thing you can do to someone. The overwhelming majority of physicians would be appalled to discover that they may be unintentionally hurting some patients. Finding ways to discuss implicit bias and to bring the issue into a physician's conscious awareness can positively enhance medical decision-making and patient-centered care. Just how powerful is implicit bias? Because that implies that for a group of people who go through years of training and in many instances deal with the entire array of ethnic, gender, racial diversity of America, that it's still that powerful. Is it all that powerful?
It is a factor that contributes to health disparities and health inequities, right? And so I never have said that it impacts every single encounter every single time. But think about how many people we prescribe aspirin to, and we're saving a small number of those people from heart attacks, but getting a heart attack is very bad, right? And so so yes, implicit bias, because of the time constraints that we work under, et cetera, as I mentioned earlier, does influence our care. It influences our communication behaviors as physicians. The studies pan out about that time after time after time. That it influences our communication, both verbal and nonverbal. And then on the patient side, it influences their perception of their confidence in our treatment. These are all studies that have been done. Their confidence in our treatment, how they think, how patient-centered they think we are. Things like shared decision-making, all the things, trust, all the things you want are being influenced, and the patient perception is influenced, which when you have a poor communication or less than the encounter you wanted, there's issues of trust, there's issues of delay in seeking care, there's avoidance of care, there's decreased medication adherence, so people don't take their medicines because they don't trust you. They kind of just, sure, whatever you say, doc, I'm leaving, right? Our research has shown a woman walked with a kidney stone for an entire week extra because when she saw the doctor, he did something that she perceived as bias. It was such an insult to her dignity that she said she got up, she left, she got her coat, went to the front desk, said, take my name off your list, I am never coming back here again, went back to her regular primary care doc, got a new referral, and saw another doctor, another specialist in a week. And she said that kidney stone, and kidney stone pain is some of the worst pain you can have, right?
Stuff.
But that's how far people will go to preserve their dignity, which means that's how powerful it is when it's happening and we're not aware of it, right?
That's powerful. So what I understand is it's powerful and it's also pervasive. Not like there's some small group or some large, it's almost all of us have these cues, if you will, that we rely upon. It simply means that in a situation of doctor-patient, it takes on literally life and death consequences in many instances. So it's not only pervasive, it's very powerful. I want to ask you a personal question now, if you don't mind. You are yourself Hispanic.
I am.
And so how much of your identity as a Hispanic physician explains your interest in this topic? Let me explain. I ask because questions arose many times in the recent past, and they continue to rise about whether and how a researcher, however well-trained in research methods, can truly understand the experiences of a person who undergoes what, by almost any standard, is prejudice. And as I noted, this arises in studies done by men about women and about Asian Americans and interviews on African Americans and about physicians, most of whom are white men, treating persons from different racial and ethnic groups. So 2 questions there. Is your background, is who you are and the experiences you had by virtue of being Hispanic, did that have an influence in guiding you to this topic? And 2, if it did, does it in some way make it harder for you to study this topic?
So the first one is much easier to answer. Yes, but probably not for what the reasons people think.
Wow.
My father's a physician. He also graduated from Einstein. My mother is also a professional.
It's in the DNA.
Yeah, right. So actually, she's a teacher. She's trained as a teacher, and she had a different career. But and my father's a physician, and I'm a physician who does medical education research. So it's kind of I got the best of both their worlds. But the way that our family trajectory went is we moved. I was born when my father was doing residency in Brooklyn, New York, and then we moved to Puerto Rico, which is where my family is from on both sides. And my dad practiced there for a while and then got a job in Pennsylvania, which is very random. And we grew up in small town Pennsylvania,
Wow.
like on a farm, I took my horse to college. And so that's to say that, so I'm in a setting where we're pretty much one of the few visibly brown families, right?
Yep.
And you know, you're a kid, you have friends, blah blah blah, but you see a lot of the we saw the racism happening when we were kids. We were cognizant of it, right? And of course, there's lots of good people. We had lots of friends. It's kind of there's people everywhere. But what I realized then was I've always been a bit of a social justice person because I saw the inequities of like my cousins in New York, let's say, in the schools that they had and the experiences they were having in the Bronx versus us in really good public schools in Pennsylvania, right? I used to be an educational justice kind of person, and then I moved to healthcare disparities as I became a healthcare provider. And it was always about the pursuit of equity in some form. And then my mentor, Dr. Paul Morantz, showed me an article about implicit bias and medical decision making. And I said to myself, I remember plain as day, and this is like at least 11 years ago. And I said, wait a minute, good people with good intentions are making decisions that are hurting patients? Yeah. He's like, yeah. I'm like, oh, I can work on that. Because I want to make it clear that because I mentioned about growing up and the racism, this is not a white person problem. Right. This is human
exactly.
to human.
I understand.
But because of my lived experience, I knew growing up, seeing both sides, seeing some of the prejudice, etc., and also seeing the goodness, I realized that a lot of good people are unintentionally hurting other people. And so what our work strives to do is to help us get the skills to be able to look back on our day and realize that we treated more people and made more medical decisions in line with our conscious egalitarian values, right? We want to do good. That's how my identity and really my lived experience led to this. And then if it's harder, I used to think it was because I used to think that people would be like, oh, Dr. Gonzalez, of course she's going to care about this stuff, right? And kind of almost diminish it, right? Diminish its importance. And then I did a faculty interview study that we published in 2018. And I interviewed like in-depth interviews with men, women, white, Hispanic, Black faculty members about their perceived challenges and opportunities for teaching about implicit bias. And what I found out was that everybody has something. One of the big themes was your perceived self-efficacy. So my white male colleagues were like, oh yeah, you think it's hard for you? Think about me. And people are like, who's this privileged white guy talking about racism? And I'm like, oh, the PhDs were like, you think you have it tough? Try being a PhD teaching in an MD school. And the students are like, you've never seen a patient, and these wonderful people, generous with their time, knowing, believing implicit bias was important to talk about, and also having all kinds of, nervousness and reticence, if you will, in the sense that they perceive that many parts of their identity might influence it. And again, it's also bias. My work is centered on race because it's it's the one that nobody wants to talk about, because it's just having that aha moment. Like, oh, it's happening, right? Let me take a step back, think through this more carefully, and deliver the excellent care I want to give in the first place. Our research has shown that it's applicable to all types of bias. right? You don't have to have like a program for race, a program for gender, a program for weight, a program
It's
for
all
religion.
the same.
Exactly.
And what I'm struck by what you just said, that when the PhD folks, who are the third class citizens of the medical world,
those are your words, not mine.
no, I'm well aware of it, and as a result, their sense of the importance of their position and identity really must it must be very painful and difficult to work through the question of bias. It reminds me, I grew up in the American South, and I've spent most of my life trying to figure out where did all these ideas I had came from. And it's not comfortable. It's not comfortable at all. One more question then.
Yes.
Yours and other researchers' studies raise some pretty difficult questions. One we just discussed, namely the majority of practicing physicians are white men, mostly of fairly affluent backgrounds. And that's true. That's been true of medicine since almost the very beginning. The challenge now, even though we have more women applying and being admitted to medical school, by the time we see any significant increase in the numbers of women, or you can choose your demographic characteristic, it seems to me it's going to be a long time before we have worked our way through and out of the detrimental effects of implicit bias. Is that true, or is this something that maybe in a generation we could deal with effectively, or are we looking at something much, much longer?
I think we're looking at something much longer, because if I understand your question correctly, if women in general over a population have less implicit bias as it comes to race, right?
Mm-hmm.
As it pertains to race, excuse me, but it's still there, and young people have less implicit bias as it pertains to race than older people. Again, by the way we're socialized, right? But I don't think it's going to go away, because we still have a very similar socialization process. Exactly. Right.
And reinforced by a lot of other structures that
right.
It's reinforced by. Yes.
It's ruined Hollywood, movies for me. It's ruined TV. It's all this work, because I'm like, oh, look how they're portraying that person. And all these kids are going to watch that. And so right. For example, like I used to think that was going to be the case when I was a much younger physician. And I remember I walked in one day and I had my intern, who was tall, handsome, white, like Midwestern kind of just tall guy, right? And he was a great intern. And we had a 22-year-old African-American patient who has presented with sickle cell pain crisis. We walk in and he looks at the intern and he says, "Oh, Dr. So-and-so, you brought your PA?" And my intern was like, "No, she's the boss." And I remember thinking, this kid is 22. This is never going to get better. I think, and again, because it's not, I want to be clear, people aren't bad because they...
No, I understand that.
I think it may get easier, though, because it's in the national parlance now since the last several years, to be able to talk about it. Young people are learning about it more and hearing about it more, so that when they get to me, it's not like, whoa. I'm not, they're more willing to engage.
There's some reason for optimism. The tragedy of George Floyd and those sense, if you look at public opinion polls, it does suggest that white Americans and others have begun to recognize that there are structures and systems that reinforce all those implicit biases. So there is some hope there. And I guess part of it, my reason for hope, is that as long as people like you are willing to give time and energy to this topic, maybe there's some hope. I want to thank you very much for being with us. Keep it up. Keep going. And the next time someone turns to the white male guy and says, "Oh, you're the doctor, and who's she?" I don't know if violence is acceptable as a response, but I hope you're able to correct him at that point. Thank you very much for being on Innovators, and the best of luck to you.
Thank you so much. I appreciate it. Thank you.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.